Our topic for this lecture is reproductive system pathophysiologies, with a specific focus on reproductive system cancers. So we're going to take a look at both benign and cancerous ovarian, cervical, and uterine growths and masses in the female. We'll differentiate between benign and cancerous breast tissue pathologies, and then we'll take a quick look, not too quick, at the two most common male reproductive system cancers, both prostate and testicular cancer. So let's start by talking about the female reproductive system and start with some ovarian cyst pathologies or pathophysiologies. There's been a lot of interest in the last 5 years or so, or perhaps maybe it's better to say a renewed interest in polycystic ovarian syndrome or PCOS. One of the reasons we have been especially interested in PCOS is its strong relationship in obesity and leading to insulin resistance, which we're going to talk about. But when we think about polycystic ovarian syndrome or PCOS, the key features of this pathology are a decrease in ovulation and an increase in androgens. Now, this hyperandrogenic state may or may not be genetically related. We're not completely sure about. However, we do have very strong associations of polycystic ovarian syndrome with obesity, metabolic syndrome, as well as ovarian and uterine cancer. So let's take a closer look at that as it relates to obese women. As we look at polycystic ovarian syndrome, all women who have PCOS have insulin resistance, and that's the key feature that we see in the obesity. With this insulin resistance, there is an increase in insulin levels as well as androgen secretion. Now, we also know that in the presence of obesity, remember we talked about fat being metabolically active as well as hormonally active. Adipose tissue also releases estrogen, so that's a player here as well. So what happens in PCOS is the insulin stimulates the ovaries to produce androgens and to decrease sex hormone binding globulins. That then leads, the net effect of that then is to increase testosterone. Remember, again, as I've just previously mentioned, adipose tissue releases estrogen. The end result then in obese women is that there is an increase in androgen as well as an increase in estrogen. However, the net effect of that is anovulation, a lack of ovulation that then leads to multiple cysts. Now, what's very interesting about that is, as I identified, all women who have PCOS have insulin resistance. However, we also know that 50% of normal weight women with PCOS also have insulin resistance. So it's an issue with the PCOS by itself as well. What happens then in polycystic ovarian syndrome is that there is a decrease in follicle stimulating hormone and an increase in luteinizing hormone. That then leads to an increase in the androgens that then convert to estrogen out in the periphery. As you have that conversion, that then continues to decrease the follicle stimulating hormone and increase the luteinizing hormone because you have the estrogen out there. So as a result, follicles begin to form, but they don't mature and rupture. And that's where you get the anovulation and the development of the cysts. A second reproductive growth in the female related to the ovary are ovarian cysts themselves. Don't confuse PCOS with the ovarian cysts we're going to talk about here. So this is a second pathology. Now, the majority of ovarian cysts are benign growths, but we can't ignore them because the vast majority of ovarian cysts are fluid-filled if they are follicular. However, if they are more solid, they are more likely to become malignant. So that's why we can't ignore them completely. There are two general types of ovarian cysts, follicular cysts and cysts that arise from the corpus luteum. With these ovarian cysts, these are these benign, usually unilateral cysts that occur when a follicle is stimulated by follicle-stimulating hormone, but it doesn't either develop to maturity, and because it doesn't develop to maturity, it ends up generally rupturing or regressing or rupturing and regressing. Again, most of these are fluid-filled. They're benign, but if they are more solid, they are more likely to either be malignant or become malignant. A less common type of ovarian cyst is a corpus luteum cyst. These cysts actually form in that vascular corpus luteum. And when that happens and they rupture, they cause abnormal uterine bleeding. Now, the question then is, well, where do these actually come from? It's believed that these corpus luteum cells are cells that are left over after ovulation. Again, very vascular, but they generally regress unless they get bigger and bigger, and then they can cause abnormal uterine bleeding. Another type of reproductive growth or mass are benign uterine growths. And there are two common, fairly common, benign uterine growths. These are endometrium polyps and myometrium, and in the myometrium, these are leomas or uterine fibroids, generally the name we might know them from. When we look at endometrium polyps, they may be hyperplastic, and if they are hyperplastic, remember a polyp is like a little mushroom kind of like structure, and these are peduncles. And these can be very hard to differentiate from the endometrial wall itself or whether it's a sarcoma. So we want to be sure we follow up on these. These may be atropic or inactive growths, or they may be more functional growths. If they're functional, generally what happens in those is that the endometrium seems out of sync with the rest, these polyps seem to be out of sync with the rest of the endometrium. Endometrium polyps are related to estrogen, and so that's an important thing to remember. The most common thing you'll see with a benign uterine growth is bleeding between the menses or an increase in menstrual flow. So you'll see abnormal uterine bleeding that needs to be investigated. A second type of benign uterine growth occurs in the myometrium, or the uterine muscle itself. And these are called leiomyomas, commonly called uterine fibroids. Now, these leiomyomas are actually extremely common, and they are frequently small and silent. The size of these myomas tends to increase with estrogen and progesterone. As a result, then, it makes sense that the peak age of the leiomyomas are between the ages of 30 to 50, and the incidence tends to drop off quite a bit dramatically after menopause. So as a result then, because the size tends to increase with estrogen and progesterone, we know that they are estrogen and progesterone sensitive. Now, these leiomyomas may be limited to the submucous layer, or they may be intramural. What's very important to remember about these leiomyomas or uterine fibroids is they are not cancerous, and they are very different from cancers. And one of the big differences, remember that cancer lecture we did early in the semester, one of the big differences is that these leiomyomas cannot produce their own blood vessels, so they don't undergo angiogenesis. They can't produce blood vessels. And remember, angiogenesis was a key factor in cancers. As a result, again, the things that we would be looking for are abnormal uterine bleeding, or there may be mass-related pressure or pain that would tell a woman that she may be developing a leiomyoma or a uterine fibroid. So what are the cause of these? Well, we talked about the link with estrogen and progesterone because many of them are estrogen, progesterone sensitive. There may also be growth factors that are associated with the development of these myomas, and there's a potential genetic link. We don't know that it's not a single gene, but it is something that we are aware of. The next piece we want to take a look at are female reproductive cancers. And the three that we're going to specifically take a look at are cervical, uterine, and ovarian. And then we're also going to talk about breast. So let's start with cervical cancer. One of the most important things we want to remember about cervical cancer is its etiology. It's estimated that at least 70% of cervical cancers is related to the cervical human papillomavirus, the human papillomavirus, so that HPV. And there are two specific types that are specifically related to dysplasia and cervical cancer, and those are HPV, human papillomavirus type 16 and 18. We also know that HPV virus can cause genital warts. Those are different subtypes. What happens here is the virus, which is a DNA virus, results in dysplastic cells that are initially precancerous. However, these cells that are dysplastic and precancerous may progress to an in situ and as well as invasive cancers. So let's think about how or why that happens. We know that this is especially that women are especially at higher risk. And we know that this cancer in situ, this localized area, develops in the transformation zone. This transformation zone is that columnar epithelial area of the cervix. And there are two different kinds of cells in the cervix. There are columnar epithelial cells and there are squamous epithelial cells. When we are younger, we have a larger and a lower transformation zone, and the cells there are those columnar epithelial cells. And those cells are more sensitive to metaplasia than the squamous epithelial cells. As we get older, we have fewer that transformation zone, or that zone where there are the columnar epithelial cells, becomes smaller and the squamous epithelial area becomes larger. So our zones change as we age to have less columnar epithelial zone area and a larger squamous epithelial area. I'm sorry. So as we age, the columnar epithelial zone is smaller and the squamous epithelial zone is larger. Therefore, younger women are at greater risk because they have more columnar epithelial cells in their cervix, and that's what's sensitive to the metaplasia. Now, the other thing that we want to think about is we know that we have, for this virus, we have a vaccine. We have an HPV vaccine. And we know that this is appropriate for both young men and young women. It's a 3-dose vaccine, but it is best given prior to sexual activity because you want to get the vaccine and confer that immunity, the vaccine effects, prior to sexual activity before they've ever got the virus. In general, we estimate that the risk is especially high within the first 3 years of becoming sexually active. So we want to get this vaccination before sexual activity. Mortality in the United States related to cervical cancer has decreased not only because of the HPV vaccine, but also because of the Pap test. Remember, that's how we check for cervical cancer. Additional risk factor for cervical cancer, not only HPV, but also smoking and chlamydia. When we think about patterns of metastasis, which we'll talk about with pretty much all of these cancers, if a cervical cancer metastasizes, it is likely to metastasize to the lungs, since you have two, the bone, and the bowel. So I would encourage you to have a sense of where these cancers metastasize as well as where they occur and how they occur. Uterine cancer is an endometrial cancer. And uterine cancer involves the glandular epithelium and is especially related to unopposed estrogen therapy. So when we think about that, why is unopposed estrogen such a huge risk for the development of uterine cancer? Estrogen is proliferative. Progesterone decreases proliferation and facilitates the shedding of the endometrium. So that's one of the reasons why we think this is so common in unopposed estrogen, because of that proliferative characteristic of estrogen. You will also see the risk of uterine cancer in someone who is anovulatory. Remember, we talked about PCOS, polycystic ovarian syndrome, as well as in women who are obese. Now, why was that? Correct. Estrogen is also produced by adipose tissue. So when we think about uterine cancer, the most common symptom is frequently abnormal uterine bleeding. And this is because of the alteration in the epithelium because of the cancerous cells. And this is especially occurs especially after menopause. So any postmenopausal woman who has uterine bleeding must be evaluated for uterine cancer. Remember that we don't have a screen for this. The Pap screen is not effective because you don't pick up endometrial cells on a Pap test. A Pap test picks up cervical cells only. Now, there are two types of uterine cancer, type 1, which is a hyperplastic or a hyperplasia, and type 2, in which the muscle itself has been invaded. So it's an extent of as well as type of cancer. Uterine cancer tends to metastasize to other pelvic structures as well as the lungs. The third reproductive cancer that we'll talk about before we turn our attention to breast cancer is ovarian cancer. We're not completely, absolutely, positively sure what causes ovarian cancer. However, we do know that some have been associated with the breast cancer 1 and 2 genes. We have identified that some of these cancers are derived from the mesoderm, and those cells migrate to the ovary. It may be from other cells actually attaching to the ovary, and that transplanted cell growth is enhanced and or even metastasized from other areas. So ovarian cancer is not one of our most common cancers. However, there are ovarian cancer causes more death than any other reproductive cancer. And why does it do that? Largely asymptomatic, and there is no screening. We do have a pretty good sense that anything that suppresses ovulation can actually decrease the risk of ovarian cancer, like pregnancy, lactation, even birth control pills. When we think about the epithelium of the types of cancer, we think about epithelial, and again, we talked about that idea of the germ cells being important. With an epithelial type ovarian cancer, the cancer actually develops from the surface of the epithelium, and it can develop from a single cell. What we believe has happened here is that there is a loss of tumor suppressing genes and or there's activation of oncogenes. Now, thankfully, the epithelial ovarian cancers are the most benign. Germ cell cancers are most likely due to errors in meiosis, which is one of our cell divisions, and these may be either benign or malignant. So ovarian cancers, while they are not especially common, are not as common as cervical or uterine, are more deadly than either of the other two. And I can't stress that ovarian cancer is causes more deaths than any other reproductive cancer. And ovarian cancers tend to metastasize to the liver. So let's move a little farther to the head, and let's talk about breast disease and breast disease pathologies. We know that breast disease can be benign or it can be cancerous. And I think that's something we need to remember because not all breast pathologies are breast cancer. At the same time, we also need to remember that not all breast diseases are benign. Breast masses are benign. McCanson-Huther has an extensive and intensive discussion of breast disease and especially breast cancer. So what I'm going to try to do is bring some organization to that, because your text will serve as an excellent resource as you enter your therapeutic management courses and as you perhaps even think about pathologies in your own families. Let's start with benign breast diseases. In benign breast diseases, there are two big categories. You have non-proliferative, which is fibrocystic breast disease, but you also have proliferative disease, which tends to be ductal and lobular. With fibrocystic non-proliferative breast disease, remember this is benign. And what happens is cysts actually develop within the breast tissue, but these cysts may grow or they may regress, calcify, or they may become chronically inflamed and become fibrotic, which is where it got the idea of fibrocystic, the idea of being cysts that can change and eventually fibrose. This is most likely related to hormone changes. Fibrocystic breast disease is most common in the 30 to 50 year age range. That's when you're most likely to identify it. And there seem to be some triggers to the fibrocystic disease in addition to hormonal changes. Some women find that they are very caffeine sensitive. Certainly the possibility of a family history and even alcohol intake has been implicated. In general, fibrocystic, this non-proliferative breast disease, occurs in the terminal duct or lobule of the breast. So remember your breast anatomy as you think about breast disease. The ducts are the tubes that carry the milk. The lobules are the structures that actually are the milk-producing glands. So let's look at ductal and lobular proliferative breast disease. Again, we're still looking at this point, benign breast disease. Now, the proliferative benign breast disease, the ductal lobular benign breast disease, may be present without atypia or with atypia. Without atypia means that there are not large numbers of atypical cells, lots of etiologies and types of reasons, and they generally present as a defined mass. However, the risk of cancer is very low because there are no atypical cells there. With atypia, however, cells with altered structures are present, but these altered cells don't have the features of cancer cells. Despite this, however, someone who has benign breast disease with atypia, there is a risk of cancer and their cancer risk is increased. So the big difference you want to remember then is do these cells demonstrate atypia or not? So without atypia, low risk of cancer. With atypia, a higher risk of cancer. This is especially important in premenopausal women, and it tends to be lobular cancer when this is atypia. In a postmenopausal woman, it may be either lobular or ductal. There doesn't seem to be a difference, but more likely to be lobular in a premenopausal female. With breast cancer, when we're looking at pathophysiology, we know that some of the influences include pregnancy, hormones, breast density, genetics, and lifestyle. We're going to go over each one of those in just a bit. We know that we also have some fairly common subtypes, and they tend to be related to receptors or factors. Estrogen receptor and progesterone receptor cancers are two of the very common subtypes. There is also, however, an HER2 positive subtype. And HER is human epidermal growth factor. We know that an individual that has an HER2 positive breast cancer has a gene mutation that increases this protein. Human epidermal growth factor is a protein that actually promotes cancer cell growth when it mutates, especially when it mutates. So an HER2 positive breast cancer has a gene mutation and that gene mutation makes that cancer more aggressive than other types. Because it's a growth factor, it's less likely to be sensitive to hormone treatment in order to treat it. However, we do have targeted therapy toward the growth factor. That's the Herceptin. And then we also, the fourth common subtype is estrogen, progesterone, and HER2 negative. So those would be negatives and the others are all positive. Breast cancer can be cancer in situ, it may be related to infection, and it may be invasive. Again, we're going to talk about that in more detail in just a bit. I didn't want to leave breast pathologies only to the female, however, because breast pathologies do occur also in men. Now, gynecomastia is something that you will frequently see in males. You will also see breast cancer in males. However, it is not common, but don't ignore the possibility if you feel a breast mass in a male. And a male does not have to exhibit gynecomastia in order to exhibit breast cancer. Gynecomastia by itself, very simply put, is enlarged breast tissue in the male, and it is related to an estrogen to testosterone imbalance. So there's more estrogen in relationship to testosterone. Some of the more common reasons that can lead to this enlarged breast tissue in the male include, who knows, that's my favorite for idiopathic, aging, obesity, adverse drug reactions, actually fairly common in leading to gynecomastia, especially in adolescent males, and then again the possibility of neoplasm. Although I want to again stress that gynecomastia does not have to be present in order for neoplasm to occur. But if you do see it, you should you should do a good breast exam on the male, just as you would on a female. So let's think then a little bit more about things that influence the pathology that we know as breast cancer. We know that breast cancer is the most common cancer in women and is the second cause of cancer death. What's the first cause of cancer death in women? Lung cancer. That wasn't a trick question. We talked about ovarian cancer. Ovarian cancer is a leading cause of reproductive system cancer. Okay, so what are some of the influences in the pathology of breast cancer? Pregnancy, hormones, and density. So let's take a look at those three first. So with pregnancy, some of the influences include There is an increased risk of breast cancer in women who are nulliparous or who had their first child after the age of 30. And this is more likely to result, or the incidence of a hormone receptive positive cancer is more likely in this population. We also have information that breast cancer, there's an increase in breast cancer within about 5 years after a pregnancy. And we believe this is related to both hormone as well as immune suppression, along with pro-inflammatory breast tissue changes. So after pregnancy, remember the breast is changing all the time. And after pregnancy, the breast once again changes. And the post-pregnancy changes have some wound healing-like mechanisms of remodeling. This remodeling is characterized by an pro-inflammatory environment. And that pro-inflammatory environment promotes the progression of tumor cells. At the same time, that pro-inflammatory environment involves macrophages. Remember, you're promoting macrophages in a pro-inflammatory environment. Macrophages, as you recall, suppress cytotoxic T cells. So we know that there are some linkages there with how the breast changes, as well as the hormones that are changing after pregnancy. Now, as we get older, our breasts undergo lobular involution. And this involution of the lobules is a progressive atrophy. This progressive atrophy, and involution is a physiologic atrophy that increases as we get older. There are fewer acini in the lobules, and those acini which are structures, are being replaced by connective tissue. With that lobular involution, with the replacement of this lobular tissue with connective tissue, this decreases the risk of breast cancer. Now, that seems counterintuitive though, doesn't it? Because we know that the rate of cancer decreases with age, although the incidence increases. So incidence goes up, but the rate decreases. And we believe that part of this is due to involution, that physiologic atrophy. We also know that hormones are very important in several breast cancers. We talked about the role of estrogen and progesterone. With estrogen, we know or with hormones in general rather, many cancers are initially hormone dependent, so they are receptor positive, or they may be, like I said, either estrogen or progesterone dependent. Estrogen has a role in signal molecules. Proteins and the signal molecules are both proteins as well as DNA. As a result then, because of its signaling molecule role, estrogen influences cell proliferation, cell differentiation, and cellular apoptosis, as well as the organization of those cells themselves. So that whole idea of the signaling and the role of estrogen in proliferation, differentiation, apoptosis, and organization becomes very important. The other two hormones, progesterone or prolactin, have also been implicated. We're not as clear about the role of progesterone and may have a more important risk in replacement therapy. Prolactin seems to also play a role via signaling pathways in developing breast cancers. There is definitely a positive association of estrogen, both endogenous and exogenous hormone replacement therapy, and breast cancer in postmenopausal women. So let's remember that association of estrogen and breast cancer in postmenopausal women. The third influence on the pathology of breast cancer is thought to be breast density itself. There is initially been identified that there's a strong association between the density of the breast tissue and invasive cancer. Now, some of those data have more recently been called into question, but it is something that we still pay attention to because we do seem to continue to find more invasive cancers in very dense breast tissues. The last two influences in breast cancer include genetics and lifestyle. Now, we've heard a lot for a number of years about two gene mutations, breast cancer 1 and breast cancer 2. Remember that breast cancer 1, that BRCA1 and BRCA2, the normal function of those substances is tumor suppression. So when they mutate, they become dominant susceptibility genes in both females and males. And remember, this is not limited to breast cancer. We talked about it in the cancer lecture when we talked about prostate cancer, and we'll mention it again when we talk about prostate cancer at the end of this lecture. So remember, the normal function of BRCA1 and BRCA2 is tumor suppression, and its role is in DNA repair. So when you get that mutation, you get a dominant susceptibility gene. Generally, BRCA1 and BRCA2 mutation cancers are ductal epithelial cancers, and they have a variety of looks, so they're heterogeneous and they're highly complex. In with that complexity are three additional ideas. One of these ideas is the idea of gene addiction, in which the cancer develops oncogenes as well as non-oncogenes. Oncogenes support the development of cancers, whereas non-oncogene genes facilitate the development and progression. With phenotype plasticity, we're thinking about the theory is an unintentional development during cancer progression. So the cells are more plastic, they are more changeable, unintentional development as the cancer progresses. And then the origin and the continual renewal of stem cells of these cancers is another important theory. When we think about lifestyle and the influence of lifestyle on the pathology of cancer, certainly one of the things, and we've talked about this before in cellular adaptation, is ionizing radiation. This is both a potential causative factor as well as a facilitating factor for the susceptibility of cancer. And then we also always want to take a look at diet and other lifestyle issues. So when we look at diet, the things that they've really been looked at are fats, red meats, and fiber. So initially we thought that diets that were high in fat, red meat, and low in fiber were carcinogenic. However, the data are very inconsistent. We do see a positive association of breast cancer with high alcohol intake, with postmenopausal weight gain, as well as obesity. However, we know once again there are still conflicting data. So I think we have to continue to follow these data, but know that these are the kinds of things we might want to explore in either our own lifestyle or in teaching healthy lifestyles, is to share the information. So if we think about three big risks that we have pretty good data on, we know that age, as we get older, the risk of breast cancer increases. Positive family history, definitely. And then that idea of breast tissue density is coming under some fire, but we're still following up with that. Let's talk then about the last three pieces of pathophysiology of breast cancer. And this is to talk about carcinoma in situ, inflammation-related breast cancer, and invasive breast cancer. So we have a sense of receptors and growth factors. We have an idea of some influences or some factors that influence pathology, whether they be genetics, lifestyle, some of the hormone influences, pregnancy, and we talked about density, but we also have to look at the location and characteristics of the cancer. So when we look at cancer in situ, the disease, the cancer is limited to the ducts and the lobules, and the important feature here is the basement membrane is preserved. So when we look at carcinoma in situ, that type of pathology is more commonly related to individuals with dense breasts, on postmenopausal hormone replacement therapy, who have developed postmenopausal obesity, and who have a genetic predisposition. So when we look at cancer in situ, we have increased communicating signals that localize the macrophages, the myofibroblasts, and the fibroblasts. This then leads to remodeling of the tissue that allows promotion of tumor proliferation. Remember once again, what do those macrophages do? They suppress the cytotoxic T cells. Our cytotoxic T cells are there to protect us. Now remember again, carcinoma in situ, that basement membrane has been preserved. It's in an area. In an inflammation-related breast cancer, the tumor environment itself essentially acts as a suppressant initially and may actually last long term. However, that environment that acts as an initial suppressant may harbor malignant cells and those cells then remain dormant for a varying length of time. So they may always be dormant, or they may wake up and not be dormant anymore. The stromal response, and the stroma is the connective or the supporting tissue response that is often associated with inflammation-related breast cancer, is associated with invasion of an inflammation-related cancer. So essentially this is a host and tumor-related healing response. Invasive cancer, breast cancer, is what happens in carcinoma in situ when that basement membrane and the myoepithelial layer has been breached. So you've got a carcinoma in situ, but when that basement membrane breaks down and the myoepithelial layer is breaking down, it's no longer in situ. Now it is invasive. And this invasive breast cancer may be due to the release of proteolytic enzymes or immunoreactive cells. And those cells may be in the myoepithelium, and the myoepithelial cells are the surrounding tumor cells releasing those proteolytic enzymes, or some of those immune active cells in the basement membrane are releasing enzymes. But the idea there is you've breached your border. Breast cancer tends to metastasize, and breast cancer has its favorite sites just like most cancers do. Metastasis in breast cancer tends to occur more commonly to the bone, the lungs, the brain, and the liver. Let's turn our attention at the end here to the male reproductive system. The two most common cancers in male in the repro system are testicular and prostate cancer. Testicular cancer affects young and middle-aged males. It is highly associated with cryptorchism, or an undescended testicle. In someone who has a unilateral undescended testicle or cryptorchism, the cancer tends to develop in the contralateral testes. So we know that undescended testicle is something that needs to be treated early because that undescended testicle is associated with cancer development. There are two types of testicular cancer. And most of these, both cancers have a germ cell etiology and may either be a seminoma or a non-seminoma. The seminoma is the least aggressive of the two. With testicular cancer, the primary manifestation is a mass in the testicle, and that mass may or may not be present. Any testicular mass needs to be evaluated. Now, are all testicular masses cancer? No, but any mass where it doesn't belong should always be investigated. Remember, young and middle-aged males are your highest population. Prostate cancer is a cancer more likely to occur in older middle-aged and middle-aged males. Oh, let me back up to testicular cancer. Metastasis. Metastasis of testicular cancer tends to be to the lungs, the liver, and the brain. Let's go back to prostate cancer. Prostate cancer is an adenosarcoma, and prostate cancer tends to develop in the periphery of the prostate gland. There's questionable whether there is diet and obesity plays a role in the development of prostate cancer. As we talked about previously, genetics plays a role. BRCA1 and BRCA2 mutations can also lead to a prostate cancer, as well as the potential for estrogen receptors. Alpha estrogen receptors lead to proliferation, inflammation, and often cause pre-malignant changes within the prostate gland itself. Now, generally what happens is, when we talked about this being an adenosarcoma in the periphery of the gland, primarily develops in that prostate epithelium, and it depends on androgen and is androgen sensitive, but we're not sure of the role of androgen in actually developing the cancer itself. What we do have a sense of is that this starts with DHEA. DHEA is dihydroxyepiandrosterone. This is a hormone that comes from your adrenal gland. That then goes to the prostate gland, which converts DHEA to testosterone. It goes to the testosterone, which converts to testosterone, and then dihydroxytestosterone, or DHT. Now, as the male gets older, there is an imbalance between estrogen and testosterone. So what happens in aging is there is more estrogen in relationship to the amount of testosterone and therefore DHT that is available. So it's an imbalance of estrogen and testosterone. Now, this is where we come up with PSA, prostate-specific antigen, can be produced by and is produced by the prostate gland. But its absolute utility in diagnosing prostate cancer has been called into question, because PSA elevates not only with cancer, it also elevates with prostatitis and with benign prostatic hypertrophy, non-cancerous prostatic hypertrophy. So rather than using it diagnostically, we are increasingly using it to trend, because if the PSA is going up in the absence of prostatitis or a relieved BPH, then we start looking for cancerous. Now, we know that cancer increases, prostate cancer increases with age. We also know that there is an increased risk in black males, anyone with a positive family history of prostate cancer, and also we talked about a positive family history of BRCA-related cancers, and females as well as males. The primary manifestation of prostate cancer is bladder outlet obstruction because the prostate does continue to grow. As the cancer cells continue to grow, they can obstruct the bladder outlet. In some males, they may not notice as much of the obstructive symptoms, but they may notice a feeling of heaviness or in rare cases may actually have some low back pain. Prostate cancer tends to metastasize to the bone and to the liver. Now, thankfully, prostate cancer, because it increases with age, most prostate cancers are very slow-growing cancers after the age of 70. So as a result, then, it becomes, if a prostate cancer is identified, the first thing is to identify, is this an aggressive cancer or a slow-growing cancer? And if it's a slow-growing cancer, then many men are faced with the decision of whether or not to undergo treatment and then what kind of treatment they wish to undergo. So we've talked about a number of different kinds of cancers and growths, as well as cancers, within the reproductive system. Much of the pathophysiology is governed by or connected to hormonal influences. So having an understanding of how hormones affect the reproductive system becomes pretty important. As we talked about, breast cancer is the most common cancer in women and the second leading cause of cancer death. And we have a lot of theories of etiology and progression, and we continue to pursue those. McCants and Huther is wonderful in this discussion, but it does get a little bit confusing. Hopefully I've been able to unconfuse part of it. Male reproductive cancer is most common in the testes and in the prostate gland, and remember, very clear differences in the age of these cancers. Testicular cancer is more common in young and middle-aged males. Prostate gland cancer is much more common as the male gets older, although we also look for positive family history and a younger occurrence in black men. I hope this has been helpful, and as I always do, I appreciate your attention. Let me know if you've got questions. Thank you.